Critical concepts: high quality CPR. Start compression within 10 seconds after recognizing cardiac arrest. Push hard, push fast, compress at a rate of 100 to 120 per minute with a depth of at least 5 cm for adults but not more than 6 cm. At least one third of the depth of the chest, approximately 5 cm for children, and at least one third of the depth of the chest, approximately 4 cm for infants. Allow complete chest recoil after each compression. Avoid leaning on the chest between compression. Minimize interruption in compression. Try to limit interruptions to less than 10 seconds. Give effective breaths. Deliver each breath over 1 second, enough to make the victim's chest rise, and avoid excessive ventilation. Completion requirement: to successfully complete the course of BLS, you must have the participation in hands-on interactive demonstration, pass the relevant test, pass the infant CPR skill test, and score at least 84% on the exam in the instructor-led course, or successfully complete the online portion of hardcore BLS course. You must pass 2 skill tests to receive your BLS course completion card. The exam is open resource according to American Heart Association. The BLS technique and sequences you will learn after one approach to a resuscitation attempt, but every situation is unique. Your response will be determined by available equipment, availability of accompanying rescuers, level of training and expertise, and local protocols. Personal protective equipment helps to protect rescuers from health or safety risk. PPE will vary based on situation and protocols. It can include a combination of items like medical gloves, eye protection, gowns or full body suits, high visibility clothing, safety footwear and safety helmets. Ask your local health authority or regulatory body about the PPE protocols for your role. The BLS provider manual has different definitions for age. So infants are those younger than 1 year of age, excluding newborns. Children are 1 year of age to puberty, with signs of puberty defined as chest or underarm hair in males and any breast development in females. And adults are adolescents, that is after the onset of puberty and older. CPR is a life-saving procedure for a victim who has signs of cardiac arrest, that is, it is unresponsive with no normal breathing and no pulse. The two key components of CPR are chest compression and breaths. High quality CPR improves a victim's chances of survival. Cardiac arrest can happen anywhere, on the street, at home, or in hospital emergency, inpatient or ICU. Elements in the system of care and order of actions in chain of survival depends upon the situation. Care will depend on whether the victim has the arrest outside the hospital or inside the hospital. Care also depends on whether the victim is an adult, a child, or an infant. Actions in the chain of survival differ according to the setting, that is, in hospital versus out of hospital, and age group. Here are the specific chains of survival. So there is early recognition and prevention, activation of emergency response, high quality CPR, advanced resuscitation, post cardiac arrest care and recovery. Pediatric out of hospital chain of survival is including prevention, activation of emergency response, high quality CPR, advanced resuscitation, post cardiac arrest care and recovery. Adult in hospital chain of survival is early recognition and prevention, activation of emergency response, high quality CPR, defibrillation, post cardiac arrest care and recovery. Out of the hospital, activation of emergency response and activation of emergency response system in the hospital setting. Chain of survival elements may be slightly different for different scenarios, but following are the key elements: prevention and preparedness, activation of emergency response system, high quality CPR including early defibrillation, advanced resuscitation interventions, post cardiac arrest care and recovery. Prevention and preparedness are the foundation of early recognition of cardiac arrest and rapid response. Out of hospital. Most out of hospital adult cardiac arrests are unexpected and happen at home. Successful outcomes depend upon early, high quality CPR and rapid defibrillation in the first few minutes after the arrest. Organized community programs that prepare the public to respond quickly to a cardiac arrest are critical to improving outcomes. Prevention includes measures to improve the health of individuals and communities. Preparedness includes public awareness programs and training to help people recognize the signs of a heart attack and cardiac arrest and take effective action. Community CPR training and emergency response system development are important. Emergency telecommunications like call talkers, dispatchers who give CPR instructions help increase the rates of bystander CPR and improve outcome. This telecommunicator assisted CPR (TCPR) enables the general public to perform high quality CPR and early defibrillation. Mobile phone apps or text messages can be used to summon members of the public who are trained in CPR. Mobile phones, apps or mapping can help rescuers locate the nearest automated external defibrillator. Widespread AED availability supports early defibrillation and saves lives. Public access defibrillator programs are designed to reduce the time to defibrillation by placing automated external defibrillator in public places and training laymen to use them. In the hospital setting, preparedness includes early recognition and rapid response to the patient who may need resuscitation. For adult patients in the hospital, cardiac arrest usually happens as a result of serious respiratory or circulatory conditions that get worse. Healthcare providers can predict and prevent many of these arrests by careful observation, preventive care, and early treatment of pre-arrest conditions. Once a provider recognizes cardiac arrest, immediate activation of the emergency response system, early high-quality CPR, and rapid defibrillation are essential. Many institutions conduct ongoing training in resuscitation response. Some maintain rapid response teams or medical emergency teams. Activating the emergency response system usually means shouting for nearby help and phoning the local emergency response number. In the workplace, every employee should know how to activate the emergency response system in their setting. The sooner a rescuer activates the emergency response system, the sooner the next level of care will arrive. In hospital, activation of emergency response is specific to each institution, and a provider may activate a code, summon the rapid response team or medical emergency team, or ask someone else to do it. The sooner provider activates the emergency response system, the sooner the next level of care will come. Out of hospital and in hospital, high quality CPR with minimal interruption and early defibrillation are the actions most closely related to good resuscitation outcomes. High quality CPR started immediately after cardiac arrest combined with early defibrillation can double or triple the chances of survival. These time sensitive interventions can be provided both by members of the public and by healthcare providers. Bystanders who are not trained in CPR should at least provide chest compressions, that is called hands only CPR. Even without training, bystanders can perform chest compression with guidance from emergency telecommunicators over the phone, that is called TCPR. Out of hospital and in hospital, advanced interventions may be performed by medically trained providers during a resuscitation attempt. Some advanced interventions are obtaining vascular access, giving medication and placing advanced airway. Others are obtaining 12-lead ECG or standing advanced cardiac monitoring. In both settings, high quality CPR and defibrillation are key interventions that are the foundation of a successful outcome. Out of hospital lay rescuers provide high quality CPR and defibrillation with AED until a multi-rescuer team takes over the resuscitation attempt. This high performance team will continue high quality CPR and defibrillation and may perform advanced interventions. In hospital, the high performance team in a hospital may include physicians, nurses, respiratory therapists, pharmacists, and others. In addition to advanced interventions, extracorporeal CPR may be used in certain resuscitation situations. After return of spontaneous circulation, all cardiac arrest victims receive post-cardiac arrest care, and post-cardiac arrest care will include routine critical care support such as artificial ventilation and blood pressure management. The care begins in the field and continues during transport to a proper hospital or medical facility. And in a hospital, a multidisciplinary team will provide advanced level of care at this point. When the cardiac resuscitation attempt is successful, providers focus on preventing the return of cardiac arrest and tailor specific therapies to improve long-term survival. Post-cardiac arrest care in hospital may occur in the emergency, in cardiac cath lab, ICU or CCU. Patient may undergo a cardiac cath procedure. During this, a catheter is inserted in artery, mostly in the groin or wrist, and threaded through the blood vessel to the patient heart to evaluate the heart function and blood flow. Some cardiac problems such as a blocked artery may be fixed or other problems diagnosed. Recovery of the patient from cardiac arrest continues long after hospital discharge. Depending on the outcome, the survivor of cardiac arrest may need specific interventions which may be needed to address the underlying cause of cardiac arrest or to provide rehabilitation of the cardiac issue. Some patients need rehabilitation on neurological recovery. Psychological support for the patient and his family are important during the recovery period. Rescuers may also benefit from psychological support. 5 key elements of chain of survival have already been discussed, which are initial support. Those elements are initial support, resuscitation teams, available resources, resuscitation constraints, and level of complexity. Here the table shows the differences between initial support, resus teams, available resources between in and out of hospital settings, and resuscitation constraints and level of complexity are the same in both settings. So the initial support in hospital depends on an in-hospital system of appropriate surveillance, monitoring, and prevention with responsive primary provider teams. Whereas in the out-of-hospital cardiac arrest, the initial support depends upon community and EMS providers for support. In hospital resuscitation teams, resuscitation efforts depend upon the smooth interaction of an institution, various departments and services such as ward, ED, cath lab, and ICU. A multidisciplinary team of professional providers may include physicians, nurses, respiratory therapists, pharmacists, counselors, and others. While out of hospital, the resuscitation depends upon lay rescuers who need to recognize an unresponsive victim and quickly activate the emergency response system. Lay rescuers who perform CPR and use AED if available until a high performance team take over resuscitation efforts, and emergency medical system EMS who transport the victim to a medical facility for continued care from the out of hospital setting. Available resources in the hospital depends upon the facility. Multidisciplinary team may have immediate access to additional personnel as well as resources of emergency department, cath lab, and ICU. While in the out of hospital settings, available resources are limited to out of hospital setting with AED availability. Local PAD program are included in emergency or first aid equipment. Untrained rescuers, TCPR provides untrained rescuers to perform high quality CPR, and emergency medical services high performance teams, the only resources may be those they brought with them. Additional backup resources and equipment may take some time in the out of hospital setting to arrive. Resuscitation constraints are factors that may affect both the settings, whether in hospital or out of hospital, like crowd control, family presence, space constraint, resources, training, patient transport, and device failure, and level of complexity with resuscitation attempts both in and out of hospital are typically complex. They require teamwork and coordination between rescuer and care providers. So, key differences in adult and pediatric chain of survival. In adults, cardiac arrest is often sudden, frequently results from a cardiac cause. However, in children, cardiac arrest is often secondary to respiratory failure or shock. Both respiratory failure and shock can be life threatening. In which locations do most out of hospital cardiac arrest occur? So the answer is homes. Which is the most common cause of cardiac arrest in children? Respiratory failure and shock is the most common cause of cardiac arrest in children. What is the third link in the adult out of hospital chain of survival? Defibrillation is the third link in the adult out of hospital chain of survival. Basic framework for CPR. Anyone can be a life-saving rescuer for a cardiac arrest victim. So the building blocks of CPR include hands-only CPR with chest compression, rescue breaths with 30:2 CPR, and multi-rescuer coordinated CPR with a high-performance team. Rescuer proficiency can be from no training to highly trained. The particular CPR skills a rescuer uses depend on several variables such as level of training, experience, and confidence, which is called rescuer proficiency. Other variables are types of victim, child versus adult, available equipment, and other rescuers. A single rescuer with limited training or who has training but limited equipment can do hands-only CPR. A rescuer with more training can do 30:2 CPR. When several rescuers are present, they can perform multi-rescuer coordinated CPR. Here are some examples. Hands-only CPR. A single rescuer with little training and no equipment who witnesses a cardiac arrest in a middle-aged man might provide only chest compression until help arrives. 30:2 CPR. A police officer trained in BLS who finds an adolescent in cardiac arrest will provide both chest compressions and breaths by using a ratio of 30 compressions to 2 breaths. High performance team. 3 emergency responders who are called to assist a woman in cardiac arrest will perform multi-rescuer coordinated CPR. Rescuer 1 performs chest compression, Rescuer 2 gives breaths with a bag mask device, Rescuer 3 uses the automated external defibrillator. Rescuer 3 also assumes the role of CPR coach. A CPR coach helps team members perform high quality CPR and minimize pauses in chest compressions. High performance rescue teams. Coordinated efforts by several rescuers during CPR may increase the chances for a successful resuscitation. High performance teams divide tasks among team members during a resuscitation attempt. As a team member, you will want to perform high quality CPR skills to make your maximum contribution to each resuscitation team effort. Main components of CPR are chest compression, airway, breathing. You will learn about each through this course. Adult BLS algorithm for healthcare providers. The adult BLS algorithm for healthcare providers outlines steps for single rescuer and multiple rescuers for an unresponsive adult. We have already discussed this algorithm in the start of our course. A rescuer who arrives at the side of a potential cardiac arrest victim should follow these sequential steps on the algorithm. Verify scene safety first. Make sure the scene is safe for you and the victim. Step 2 is check for responsiveness. Tape the victim's shoulder. Shout, "Are you okay?" If the victim is not responsive, activate the emergency response system via mobile device. Get the automated external defibrillator or send someone to do so. Step 3 is assessment of breathing and pulse. Check for pulse to determine next actions. To minimize delay in starting CPR, you should assess breathing and pulse at the same time. This should take no more than 10 seconds. Step 3A and B determine next actions based on whether breathing is normal and if a pulse is felt. If the victim is breathing normally and pulse is felt, monitor the victim. If the victim is not breathing normally but a pulse is felt, provide rescue breathing at a rate of 1 breath every 6 seconds or 10 breaths per minute. Check for a pulse about every 2 minutes. Perform high quality CPR if you do not feel a pulse. If you suspect opioid use, give naloxone if available and follow your local protocols. If the victim is not breathing normally or is only gasping and has no pulse, begin high quality CPR. In step 4, start high quality CPR with 30 chest compressions followed by 2 breaths and use an AED as soon as it is available. In step 5 and 6, use the AED as soon as it is available. Follow the AED directions to check the rhythm. In step 7, if the AED detects a shockable rhythm, give one shock. Resume CPR immediately until prompted by AED to allow a rhythm check about every 2 minutes. Continue CPR and using the AED until advanced life support providers take over or the victim begins to breathe or move or otherwise react. In step 8, if the AED detects a non-shockable rhythm, resume high-quality CPR until prompted by the AED to allow a rhythm check about every 2 minutes. Continue CPR and using the AED until advanced life support providers take over or the victim begins to breathe, move, or otherwise react. High quality CPR skills. Learning the skill in this section is for high quality CPR. Assess for breathing and pulse. Assess the victim for normal breathing and a pulse as shown in the figure. To minimize delay in starting CPR, you should assess breathing at same time as you check the pulse. This should take at least 5 seconds but no more than 10 seconds. Breathing. To check for breathing, scan the victim's chest for rise and fall for no more than 10 seconds, and if the victim is breathing, monitor the victim until additional help arrives, and if the victim is not breathing or is only gasping, be prepared to begin high quality CPR. Gasping is not normal breathing and is a sign of cardiac arrest. Critical concepts. Agonal gaps. Agonal gaps may be present in first minutes after sudden cardiac arrest. Agonal gaps are not normal breathing. A person who gasps usually appear to be drawing air in very quickly. The mouth may be open and the jaw, head, or neck may move with gasps. Gasps may appear forceful or weak sometimes. May pass between gasps because they usually happen at a slow, irregular rate. The gasp may sound like a snort, snore, or groan. Gasping is not normal breathing, it is a sign of cardiac arrest. Checking for carotid pulse on an adult. To perform a pulse check on an adult, feel for a carotid pulse. If you do not feel a pulse within 10 seconds, definitely begin high quality CPR starting with chest compression. Follows these steps to find and feel for the carotid pulse. First, locate the trachea on the side closest to you using 2 or 3 fingers. Slide those fingers into the groove between the trachea and muscles at the side of the neck where you can feel the carotid pulse. Feel for a pulse for at least 5 but no more than 10 seconds. If you do not definitely feel a pulse, begin CPR starting with chest compressions. In all scenarios, by the time a breathing and pulse check indicates cardiac arrest, the following should already be happening. Someone has activated the emergency response system. Someone has gone to get the automated external defibrillator. Perform high quality chest compressions. The foundation of CPR is high quality chest compressions. Compressing the chest during CPR pumps blood from the heart to brain and then to rest of the body. Each time you stop chest compression, the blood flow from the heart to brain and other organs decrease significantly. Once you resume compression, it takes several compressions to bring the blood flow back up to the levels present before the interruption. Thus, the more often you interrupt chest compression and the longer the interruptions are, the lower the blood supply to brain and vital organs. When a victim is not breathing normally or is only gasping and has no pulse, begin CPR starting with chest compression. Position the victim face up on a firm flat surface such as floor or a backboard. This will help ensure that the chest compressions are as effective as possible. If the victim is on a soft surface such as a mattress, the force from chest compression will simply push the victim's body into the soft surface. A firm surface allows compression of the chest and heart to create adequate blood flow. Compression to ventilation ratio. Single rescuer should use the compression to ventilation ratio of 30 compressions to 2 breaths when giving CPR to victims of any age, and compression rate at 100 to 120 per minute. This rate is the same for compressions in all cardiac arrest victims. Compression depth. Compress the chest at least 5 centimeters. As you practice this skill, remember that chest compressions are more often too shallow than too deep. However, it is possible to compress too deeply. Compressing the chest more than 6 cm in adults may decrease effectiveness of compression and cause injuries. Using a CPR quality feedback device can help you reach the optimal compression depths of 5 to 6 cm. Chest recoil. Allow the chest to recoil, re-expand completely after each compression. Chest recoil, re-expansion of chest allows blood to flow into the heart. Incomplete chest recoil reduces the filling of the heart between compressions and reduces the blood flow created by chest compressions. To help ensure complete recoil, avoid leaning on the chest between compressions. Chest compression and chest recoil times should be about equal. Interruptions in chest compressions. Minimize interruption in chest compression. Shorter duration of interruption in chest compression is associated with better outcome. The proportion of time that rescuers perform chest compressions during CPR is called chest compression fraction. A chest compression fraction of at least 60% increases the likelihood of return of spontaneous circulation, shock success, and survival to hospital discharge. With good teamwork and training, rescuers can often achieve 80% or greater. This should be the goal in all team resuscitation events. Do not remove the victim while CPR is in progress unless the victim is in a dangerous environment such as burning building or you believe you cannot perform CPR effectively under the current circumstances. When help arrives, the resuscitation team, because of a local protocol, may choose to continue CPR at a scene or transport the victim to an appropriate facility where while continuing the rescue efforts. High quality BLS is key at all times during the resuscitation event. Chest compression technique. Follow these steps to perform chest compression on an adult. Position yourself at the victim's side. Make sure the victim is lying face up or on a firm flat surface. If the victim is face down, carefully roll the person over. If you suspect a head or neck injury, try to keep the head, neck, and torso in a line while rolling the victim to a face up position. It is best if someone can assist you in rolling the victim. Position your hands and body to perform chest compressions. Place the heel of one hand in the center of the victim's chest on the lower half of the sternum. Put the heel of your other hand on top of the first hand. Straighten your arm and position your shoulders directly over your hands. Give chest compression at a rate of 100 to 120 per minute. Press down at least 5 cm with each compression. This requires hard work. For each chest compression, make sure you push straight down on the victim's breastbone. Alternate technique for chest compression. If you have difficulty pushing deeply during compressions, do the following. Put one hand on the breastbone to push on the chest. Grasp the wrist of that hand with your other hand to support the first hand as you push down on the chest. This technique may be helpful for rescuers with joint conditions such as arthritis. Compression of a pregnant woman. Do not delay providing chest compressions for a pregnant woman in cardiac arrest. High quality CPR, including respiratory support and early medical intervention, can increase the mother's and the infant's chance of survival. If you do not perform CPR on a pregnant woman when needed, the lives of both the mother and the infant are at risk. Perform high quality chest compressions and ventilations for a pregnant woman just as you would for any victim of cardiac arrest. Be aware that when a visibly pregnant woman, approximately 20 weeks, is lying flat on her back, the uterus compresses the large blood vessels in the abdomen. This pressure can interfere with the blood flow to the heart generated by the chest compression. Manual lateral uterine displacement LUD, that is manually moving the uterus to the patient's left to relieve the pressure on the large blood vessels, can help relieve this pressure. If additional rescuers are present and rescuers are trained, perform continuous LUD in addition to high quality BLS. If the woman is revived, place her on her left side. This may help improve blood flow to her heart and therefore to the baby. Manual LUD during CPR, one-handed technique, and in the figure 9b, two-handed technique. Critical concepts. Perform high quality chest compressions. Use a ratio of 30 compressions to 2 breaths, compressed at a rate of 100 to 120 per minute with a depth of at least 5 cm for adults. Allow complete chest recoil after each compression. Do not lean on the chest between compressions. Minimize interruptions in chest compression. Try to limit pauses in compressions to less than 10 seconds. The goal is a CCF of at least 60%. With good teamwork, rescuers can often achieve 80% or higher. Give breaths. Opening the airway. For breaths to be effective, the victim's airway must be open. Two methods for opening the airway are head tilt, chin lift, jaw thrust. Important, if you suspect a head or neck injury, use the jaw thrust maneuver to reduce neck and spine movement. If the jaw thrust does not open the airway, use the head tilt chin lift maneuver. When multiple rescuers are available, one rescuer can perform a jaw thrust while another rescuer provides breaths with a bag mask device. The third rescuer will give chest compression. Head tilt chin lift. Follow these steps to perform a head tilt chin lift. Place one hand on the victim's
forehead and push with your palm to tilt the head back. Place the fingers of the other hand under the bony part of the lower jaw near the chin. Lift the jaw to bring the chin forward. When performing a head tilt chin lift, make certain that you avoid pressing deeply into the soft tissue under the chin because this might block the airway. Do not close the victim's mouth completely. As in the figure, the head tilt chin lift maneuver. A. Obstruction by the tongue. When a victim is unresponsive, the tongue can block the upper airway. In figure 10b, it is shown that the head tilt and chin lift maneuver lifts the tongue, relieving the airway obstruction. Jaw thrust. When the head tilt chin lift does not work or when you suspect a spinal injury, use the jaw thrust maneuver. Follow these steps to perform jaw thrust. First, position yourself at the victim's head. Place one hand on each side of the victim's head. You may rest your elbows on the surface where victim is lying. Place your fingers on the angle of the victim's lower jaw and lift with both hands, displacing the jaw forward. If the victim's lips close, push the lower lip with your thumbs to open the lips. If the jaw thrust does not open the airway, use a head tilt chin lift maneuver. In this figure, you can see the jaw thrust maneuver.
Barrier devices for giving breaths. When giving breaths during CPR, standard precaution is to use a barrier device. Example are pocket masks preferred and face shields. Rescuers should replace face shields with a pocket mask at the first opportunity. Infection from CPR is extremely unlikely. Only a few cases have been reported. Yet the local safety and health protocols may require that healthcare workers use standard precautions while performing CPR in the workplace. Pocket masks. Pocket masks for mouth to mask breaths. Use a pocket mask. Pocket masks usually have a one-way valve that diverts exhaled air, blood, or bodily fluid away from the rescuer. The one-way valve allows the rescuer breath to enter the victim's mouth and nose and diverts the victim's exhaled air away from the rescuer. Pocket masks are available in different sizes for adults, children, and infants. Effective use of the pocket mask barrier device requires instruction and practice. To use a pocket mask, position yourself at the victim's side. This position is ideal for one rescuer CPR because you can give breaths and perform chest compressions without repositioning yourself every time you change from compressions to give breaths. Follow these steps to open the airway with a head tilt chin lift and give breaths with a pocket mask. First, position yourself at the victim's side. Place the pocket mask on the victim's face using the bridge of the nose as a guide for correct positioning. Seal the pocket mask against the face using your hand that is closer to the top of the victim's head. Place your index finger and thumb along the top edge of the mask. Place the thumb of your other hand along the bottom edge of the mask. Place the remaining fingers of your second hand along the bony margin of jaw and lift the jaw. Perform a head tilt chin lift to open the airway. While you lift the jaw, press firmly and completely around the outside edge of the mask to seal the pocket mask against the face. Deliver each breath over 1 second, enough to make the victim's chest rise. Remember, when interrupting chest compressions, to give 2 breaths with a barrier device. Be sure that you deliver each breath over 1 second. Note visible chest rise with each breath. Resume chest compression in less than 10 seconds. The air we breathe has 21% oxygen and the one which we breathe out has 17% oxygen. Enough oxygen to provide the victim with much needed oxygen. Use a bag mark Use a bag mask device if available to provide positive pressure ventilation to a victim who is either not breathing or not breathing normally. The device consists of a bag attached to a face mask. If the bag is self-inflating, you may use it with or without oxygen supply. If not attached to oxygen flow, it provides 21% oxygen from room air. Some bag mask devices include a one-way valve. The type of valve may vary from one device to another. Face masks are available in variety of sizes. Common sizes are infant small, child medium, and adult large. For a proper fit, the mask should extend from the bridge of the nose to just above the lower edge of the chin. Cover the nose and mouth. Make sure the mask does not apply pressure to the eyes. Flexible cushioned mask should provide airtight seal. If the seal is not airtight, ventilation will be ineffective. Bag mask ventilation during CPR is more effective when two rescuers provide it together. One rescuer opens the airway and seals the mask against the face while the other squeezes the bag. All BLS providers should be able to use a bag mask device. Proficiency in this ventilation technique requires practice. Bag mask ventilation technique. One rescuer to open the airway with a head tilt chin lift and use a bag mask device to give breath to the victim. Follow these steps. First, position yourself directly above the victim's head. Place the mask on the victim's face using the bridge of nose as a guide for correct positioning. Use the EC clamp technique to hold the mask in place while you lift the jaw to hold the airway open. Perform a head tilt. Place the mask on the face with the narrow portion at the bridge of the nose. Use thumb and index finger of one hand to make a C on the side of the mask, letter C, pressing the edges of the mask to the face. Use the remaining fingers to lift the angle of the jaw. Three fingers will form an E alphabet shape. Open the airway and press the face to the mask. Squeeze the bag to give breath while watching for chest rise. Deliver each breath over 1 second with or without the use of supplemental oxygen. Bag mask ventilation technique. Two or more rescuers. Bag mask ventilation technique. Two or more rescuers. When three or more rescuers are present, two of them working together can provide more effective and efficient bag mask ventilation than one rescuer can. Two rescuers work together in this way. Rescuer one position directly above the victim opens the airway and positions the bag mask device following the steps described in the bag mask ventilation technique. This rescuer should be careful not to press too hard on the mask because doing so could push the patient jaw down and block the airway. Rescuer 2 positioned at the victim side squeezes the bag. Ventilation for a victim with a stoma or tracheostomy tube. When ventilating a victim who has stoma or tracheostomy tube, position a mask over the stoma or tube and use the previously described technique. A pediatric mask may be more effective than an adult mask. If the chest doesn't rise, you may connect the bag mask device directly to the tracheostomy tube. If the chest still don't rise, you may need to close the victim mouth while providing breaths over the stoma or tracheostomy tube. Critical concepts. Two rescuers for jaw thrust and bag mask ventilation. During CPR, jaw thrust and bag mask ventilation are more efficiently performed when two or more rescuers are providing ventilation. One rescuer must be positioned above the victim's head and use both hands to open the airway, lift the jaw, and hold the mask to the face, while the second rescuer squeezes the bag. The second rescuer is positioned at the victim's side. Adult 2 rescuer BLS. When you encounter an unresponsive adult and other rescuers are available, work together to follow the steps outlined in adult BLS algorithm for healthcare providers. When more rescuers are available for resuscitation attempt, more tasks can be performed at the same time. The first rescuer who arrives at the side of the potential cardiac arrest victim should quickly assess the scene for safety and check the victim for responsiveness. This rescuer should send another rescuer to activate the emergency response system and get the AED As more rescuers arrive assigned tasks, additional rescuers can help with bag mask ventilation, compression, and using the automated external defibrillator. For complete step-by-step instruction on following the adult BLS algorithm, we have already discussed it in the initial of our videos. Team roles and duties for two or more rescues. When more rescues are available for a resuscitation attempt, they can perform more tasks at the same time. In two rescues CPR, each rescuer has specific role. So position yourself at the victim side. Make sure the victim is face up on a firm flat surface. Chest compressions 100 to 120 per minute, at least 5 centimeter depth for adults. Allow chest recoil. Avoid leaning on the victim chest between compression. Minimize interruption. Try to limit any interruption in chest compression to less than 10 seconds. Use a compression to ventilation ratio of 30:2. Count compression loud. Switch compressors about every 5 cycles or every 2 minutes, more frequently if fatigue. Take less than 5 seconds to switch. Provide breaths. Rescuer 2 will provide breath and position himself at the victim head. Maintain an open airway by using either head tilt, chin lift, or jaw thrust. Give breaths watching for chest rise and avoiding excessive ventilation. Encourage the first rescuer to perform compressions that are deep enough and fast enough. Allow complete chest recoil between compressions. When only two rescuers are available, switch with the compressor about every 5 cycles or every 2 minutes, taking less than 5 seconds to switch. Critical concepts for high performance teams: when giving compressions, rescuers should switch compressors every 5 cycles or every 2 minutes or sooner if fatigued. As additional rescuers arrive, they can help with bag mask, ventilation, compression, using AED and other emergency equipment. Effective team performance to minimize interruption in compression. Effective teams communicate continuously. If compressor count out loud, the rescuer providing breath can anticipate when to give breaths. This will help the rescuer prepare to give breaths efficiently and minimize interruptions in compressions. Also, the count will alert both the rescuers when the time for a switch is approaching. Delivering effective chest compression is hard work. If compressor tires, chest compression will not be as effective. To reduce rescuer fatigue, compressors compressors are switching every 5 cycles or every 2 minutes or sooner if needed. To minimize interruption, switch roles when the AED is analyzing the rhythm. Take less than 5 seconds to switch. Some BLS providers have special training in coaching CPR to help the resuscitation team minimize interruption in chest compressions. This role is called CPR coach. What is a CPR coach? Many resuscitation teams now include the role of a CPR coach. The CPR coach supports performance of high quality BLS skills, allowing the team leaders to focus on other aspects of clinical care. Studies have shown that resuscitation team with a CPR coach performs high quality CPR with higher CCF and shorter pause durations than teams that do not use a CPR coach. The CPR coach does not need to be a separate role. It can be most effectively blended into the current responsibilities of the monitor or defibrillator. The CPR coach's main responsibilities are to help team members provide high quality CPR and minimize pauses in compressions. The CPR coach needs a direct line of sight to the compressor, so they should stand next to the defibrillator. Here is a description of the CPR coach's action. Coordinate the start of CPR. As soon as patient is identified as having no pulse, the CPR coach says, "I am the CPR coach," and tells rescuers to begin chest compressions. The CPR coach can adjust the environment to help ensure high quality CPR. They can lower the bed rails of the bed, get a step stool, or roll the victim to place a backboard and defibrillator pads to better facilitate high quality CPR. Coach to improve the quality of chest compressions. The CPR coach gives feedback about performance of compression depth, rate, and chest recoil. They state the CPR feedback devices data to help the compressor improve performance. This is useful because visual assessment of CPR quality is often inaccurate. State the mid-range targets. The CPR coach states the specific mid-range targets so that compressions and ventilation are within the recommended range. For example, they should tell the compressor to compress at a rate of 110 per minute instead of a rate between 100 and 120 per minute. Coach to the mid-range targets. The CPR coach gives team members feedback about their ventilation rate and volume. If needed, they also remind the team about compression to ventilation ratio. Help minimize the length of pauses in compressions. The CPR coach communicates with the team to help minimize the length of pauses in compression. Pauses happen when the team defibrillates, switches compressors, and places an advanced airway. A 53-year-old man collapses and becomes unresponsive. You witness his collapse and are the first rescuer at the scene, where the man is lying motionless on the floor. Which is the first action you should take in this situation? Activate emergency response system. Start high quality CPR beginning with chest compressions. Start providing rescue breaths. Verify that the scene is safe for you and the victim. So the answer is verify that the scene is safe for you and the victim. The man does not respond when you tap on his shoulders and shout, "Are you okay?" What is your best next action? Check his pulse. Start high quality CPR. Start providing rescue breaths. Shout for nearby help. The answer is that you shout for nearby help. Several rescuers respond and you ask them to activate the emergency response system and retrieve the AED. As you check for a pulse and breathing, you notice that the man is gasping for air and making snorting sound. What you do not feel a pulse. What is your best next action? Start high quality CPR beginning with chest compression. Monitor the victim until additional more experienced help arrives. Provide rescue breathing by delivering one breath every 6 seconds. Find someone to help by retrieving the nearest AED. The answer is that you will start high quality CPR beginning with chest compressions. What is the ratio of chest compression to breaths when providing CPR to an adult? 30 compressions to 2 breaths is the ratio of chest compressions to breaths when providing CPR to an adult. What are the rate and depth for chest compressions on an adult? A rate of 100 to 120 compressions per minute and a depth of at least 5 centimeters. What action should you take when more rescuers arrive? Assign tasks to other rescuers and rotate compressors every 2 minutes or more frequently if needed to avoid fatigue. If you suspect that an unresponsive victim has head or neck trauma, what is the preferred method for opening the airway? Head tilt, chin lift, jaw thrust, head tilt, neck lift. Avoid opening the airway. Jaw thrust is the preferred method for opening the airway if the suspect has head or neck trauma. What is CCF? CCF is proportion of time that rescuers perform chest compressions during CPR. Defibrillation. The AED identifies abnormal heart rhythm as shockable or non-shockable. Shockable rhythms are treated with defibrillation. Defibrillation is the medical term for interrupting or stopping an abnormal heart rhythm by using controlled electrical shocks. The shock stops the abnormal rhythm. This resets the heart electrical system so a normal organized heart rhythm can return. If effective circulation returns, the victim's heart muscle is once again able to pump blood. The victim will have a heartbeat that produces a palpable pulse, a pulse that can be felt by the rescuer. This is called return of spontaneous circulation or ROSC. Signs of ROSC include breathing, coughing, or movement, and a palpable pulse or measurable blood pressure. Early defibrillation increases the chance of survival from cardiac arrest that is caused by an abnormal or irregular heart rhythm or an arrhythmia. Arrhythmias occur when the electrical impulses that cause the heart to beat happen too quickly, too slowly, or erratically. Two life-threatening, shockable arrhythmias that can causes cardiac arrest are pulseless ventricular tachycardia and ventricular fibrillation. Pulseless ventricular tachycardia. When the lower chambers of the heart, that is, ventricles, begin contracting at a very fast pace, a rapid heart rate known as ventricular tachycardia develops. In extremely severe cases, the ventricles pump so quickly and ineffectively that there is no detectable pulse, that is, pulseless in PVT. Body tissues and organs, especially the heart and brain, no longer receive oxygen. Ventricular fibrillation. In this arrest rhythm, the heart electrical activity becomes chaotic. The heart muscle quiver in a fast, unsynchronized way so that the heart does not pump blood. Early defibrillation, high quality CPR, and all components of the chain of survival are necessary to improve chances of survival from pulseless VT and ventricular fibrillation. Public access defibrillator programs. To provide early defibrillation, rescuers need to have an AED immediately available. Public access defibrillation PAD programs increase AED availability and train lay people how to use them. PED programs place AEDs in public places where large number of people gather, such as office buildings, airports, convention centers, and schools. They also place AEDs in communities where people are at higher risk for cardiac arrest, such as office buildings, casinos, and apartment buildings. Some PAD programs coordinate with local emergency medical services so that telecommunicators can direct callers to the nearest automated external defibrillator. Critical concepts: maintaining the AED and supplies. AED should be properly maintained according to manufacturer's instructions. Someone should be designated to do the following: maintain the battery, order and replace supplies, including AED pads, adult and pediatric, replace used equipment, including barrier devices, for example, pocket masks, gloves, razors for shaving hairy chests, and scissors. These items are sometimes kept in a separate emergency or first aid kit. AED arrival. Once the AED arrives, place it on the victim side near the rescuer who will operate it. This position provides ready access to AED controls and help ensure easy placement of AED pads. It also allows a second rescuer to continue high quality CPR from the opposite side of the victim without interfering with AED operation. Ensure that AED pads are placed directly on the skin and not placed over clothing, medication, patches, or implanted devices. Using the AED. Know your AED. AED equipment varies according to the model and manufacturer, but all AEDs operate in basically the same way. The universal steps for operating an AED can guide you in most situations. However, you should still be familiar with the AED used in your setting. For example, it is important to know whether you must manually power on your AED or whether it powers on automatically when you open the lid. Operating AED. Universal steps. Begin by opening the AED. If needed, power it on. During the resuscitation attempt, follow the AED's prompts. These may be electronic voice prompts or digital screen prompts. To reduce the time to shock delivery, try to perform the following two steps within 30 seconds after the AED arrives at the victim's side. Open the carrying case if applicable, power on the AED if needed. Some devices power on automatically when you open the lid or case. Follow the AED prompts. Attach the AED pads to the victim's bare chest. Avoid placing the pads over clothing, medication patches, or implanted devices. Choose adult pads for victims 8 years of age and older. This should be done while a second rescuer continues CPR. Peel the backing away from the AED pads. Attach the adhesive AED pads to the victim's bare chest. Follow the placement diagram on the pad. See critical concepts later in part 4 for common placement options. Attach AED connecting cables to the AED device. Some AEDs have pre-connected cables. Clear the victim and allow the AED to analyze the rhythm. When AED prompts you, clear the victim during analysis. Be sure no one is touching the victim, not even the rescuer in charge of giving breaths. Some AEDs will tell you to push a button to allow the AED to begin analyzing the heart rhythm. Other will analyze automatically. The AED may take a few seconds to analyze. The AED then tells you if the victim needs a shock. If the AED advises a shock, it will tell you to clear the victim and then deliver a shock. Before delivering the shock, clear the victim. Do this by making sure that no one is touching the victim. Loudly state a clear the victim message such as everybody clear. Look to be sure that no one is in contact with the victim. Press the shock button. The shock will produce a sudden contraction of the victim's muscle. If AED prompts that no shock is advised or after any shock is delivered, immediately resume CPR, starting with chest compression. After about 5 cycles or 2 minutes of CPR, the AED will prompt you to repeat steps 3 and 4. The figure showing powering on of the AED. The AED operator attaches the pad to the victim and then attaches the electrodes to the AED. The AED operator clears the victim before rhythm analysis. If needed, the AED operator then activates the analyze feature of the AED. And in this figure, the AED operator clears the victim before delivering a shock. When everyone is clear of the victim, the AED operator presses the shock button. If no shock is indicated, and immediately after any shock delivered, rescuers start CPR beginning with chest compressions. Minimize time between last compression and shock delivery. Research has shown that shorter the time between the last compression and shock delivery, the better the chances of ROSC. Minimizing interruptions require practice and team coordination, especially between the compressor and the AED operator. Do not delay high quality CPR after AED use. Immediately resume high quality CPR, starting with chest compressions after either of the following. The AED operator delivers a shock. The AED prompts no shock advised. After about 5 cycles or 2 minutes of high quality CPR, the AED will prompt you to repeat step 3 and 4. Continue until advanced life support providers take over or the victim begins to breathe, move, or otherwise react. Critical concepts: AED pad placement option. Place AED pads by following the diagram on the pads. The two common placement are anterolateral and anteroposterior. Anterolateral placement is placing both pads on the victim bare chest. Place one AED pad directly below the right collarbone or clavicle. Place the other pad to the right side, to the side of the left nipple, with the top edge of the pad 7 to 8 cm below the armpit on the left side. Anteroposterior placement: place one pad in the center of the victim's bare chest anterior and the other pad in the center of the victim back posterior, or place one AED pad on the left side of the chest between the left side of the victim's breastbone and left nipple. Place the other pad on the left side of the victim's back. next to the spine. Always place pads directly on the skin and avoid contact with clothing, medication patches, and implanted devices. AED placement in the 25A figure anterolateral and in the 25B figure anteroposterior. Child AED pads. Your AED may include smaller pads designed specifically for children younger than 8 years of age. Do not use the child pads for an adult. Child pads deliver a shock dose that is too low for an adult and will likely not be successful. It is better to provide high quality CPR than to attempt to shock an adult victim with child pads. When placing AED pads, you may need to take additional actions when the victim has a hairy chest, is immersed in water or has water or liquid covering the chest, has an implanted defibrillator or pacemaker, has a transdermal medication patch or other object on the surface of the skin where you need to place the AED pads, is a pregnant woman, is wearing jewelry or bulky clothing. Hairy chest. The AED pads may stick to the chest hair and not to the skin on the chest. If this occurs, the AED will not be able to analyze the victim's heart rhythm and will display a check electrode or check electrode pads message. Remember to note whether the victim has a hairy chest before you apply the pads. Then, if needed, use the razor from AED carrying case to shave the area where you will place the pads. If you do not have a razor but do have a second set of pads, use the first set to remove the hair. Apply the first set of pads. Press them down so that they stick as much as possible and quickly pull them off. Then apply the new second set of pads. Presence of water or other liquid. Water and other liquids conduct electricity. Do not use an AED in water. If the victim is in water, pull the victim out of the water. If the chest is covered with water or sweat, quickly wipe the chest before attaching AED pads. If the victim is lying on snow or in a small puddle, you may use the AED after quickly wiping the chest. Implanted defibrillator and pacemakers. Victims with a high risk for sudden cardiac arrest may have implanted defibrillators or pacemakers that automatically deliver shocks directly to the heart. If you place an AED pad directly over an implanted medical device, the implanted device may interfere with delivery of shock. These devices are easy to identify because they create a hard lump beneath the skin that is most often in the left upper chest but can also be found in the right upper chest or abdomen. The lump can range from the size of the silver dollar to half the size of a deck of playing cards. If you identify an implantable defibrillator or pacemaker, if possible, avoid placing the AED pad directly over the implanted device. Follow the normal steps for operating an AED otherwise. Transdermal medication patches. Do not place AED pads directly on top of a medication patch. The patch may interfere with transfer of energy from AED pad to the heart. This could also cause small burns to the skin. Examples of medication patches are nitroglycerin, nicotine, pain medication, and hormone replacement therapy patches. If it will not delay shock delivery, remove the patch and wipe the area before attaching the AED pad. To avoid the transfer of medication from patch to you, wear protective gloves or use another type of barrier when removing the patch. Remember to avoid delay as much as possible. Pregnant women. You should use an AED for a pregnant woman in cardiac arrest as you would for any cardiac arrest victim. Shock from the AED will not harm the baby. Without life-saving treatment to the mother, the baby will not likely survive. If the woman is revived, place her on her left side. This helps improve blood flow to her heart and therefore to the baby. Clothing and jewelry. Quickly move bulky clothes out of the way. If a person's clothes are difficult to remove, you can still provide compressions over clothing. If an AED becomes available, remove all clothes that cover the chest because Pads must not be placed over clothing. You do not need to remove a person's jewelry as long as it does not come into contact with the AED pads. Review questions. What is the most appropriate first step to take as soon as the AED arrives at the victim's site? Power on the AED is the first step. Which step is one of the universal steps for operating an AED? Placing the pads on the victim's bare chest is the universal one of the universal steps for operating an AED. Avoid placing the AED pad directly over the implanted device. What action should you take while the AED is analyzing the heart rhythm? Stand clear of the victim. Positions for a 6-person high performance team: airway, a timer or a recorder, a compressor which rotates after every 2 minutes, a CPR coach, a medication IV or intraosseous drug administration, and a team leader. This is a suggested team formation. Resuscitation triangle roles. Compressor assesses the patient, perform compressions according to local protocols, rotates every 2 minutes or earlier if fatigued. A monitor or defibrillator or CPR coach brings and operates the AED, or monitor or defibrillator and acts as the CPR coach if designated. If a monitor is present, places it in position where it can be seen by the team leader and most of the team. Airway. Opens the airway, provides bag mask ventilation, inserts airway adjuncts as appropriate. Leadership roles. Team leader. Every resuscitation team must have a defined leader. Assigns roles to team members, make treatment decisions, provide feedback to the rest of the team as needed, assume responsibility for roles not defined. IV intraosseous medications and ALS provide a role, initiate IV or intraosseous access, administer medications. Timer or recorder records the time of interventions and medications and announces when these are due. Records the frequency and duration of interruption in compression, communicates those to the team leader and the rest of the team. As a BLS provider, you may be involved in a multi-rescue or resuscitation attempt. Effective team dynamics increase the chances of a successful resuscitation. Everyone on the team must understand not just what to do in a resuscitation attempt, but how to communicate and perform effectively as part of a multi-rescuer team. Elements of effective team dynamics. A successful resuscitation attempt depends upon high quality resuscitation skills, good communication, and effective team dynamics. All rescuers on the team must be able to respond rapidly and effectively in an emergency situation. Effective multi rescuer team dynamics help give victims the best chance of survival. Team dynamics during a resuscitation attempt includes three elements: roles and responsibilities, communication, and debriefing. Roles and responsibilities. Because every second matters during a resuscitation attempt, it is important to define clear roles and responsibilities as soon as possible. Assign roles and responsibilities. When all team members know their jobs and responsibilities, the team functions more smoothly. Rescuers should clearly define roles as soon as possible and delegate tasks according to each team member's skill level. As soon as the victim is identified as pulseless, the CPR coach will identify themselves and prompt the compressor to begin chest compression. Know your limitations. All team members should know their limitations. The team leader needs to be aware of them as well. For example, advanced life support providers may be able to perform tasks that BLS providers would not be permitted to do. Some of these tasks are administering medications and performing intubations. Each team member should ask for assistance and advice early before a situation starts to get worse. Offer constructive intervention. Whether you are a team member or a team leader, there may be times when you need to point out another team member's incorrect or inappropriate actions. When this happens, it is important to intervene in a tactful and constructive way. This is especially important if someone is about to make a mistake on a drug, a dose, or an intervention. Anyone on the team should speak up to stop someone else from making a mistake regardless of role. Communication. Share knowledge. Knowledge sharing is important for effective team performance. Not only can it help ensure that everyone fully understands the situation, but it can also help the team treat patients more efficiently and effectively. Team leaders should frequently ask for observations and feedback. This includes asking for good ideas about managing a resuscitation attempt as well as for observations about possible oversights. Summarize and re-evaluate. Summarizing information allowed is helpful during a resuscitation attempt because it provides an ongoing record of treatment. It is a way to re-evaluate the victim's status, the interventions, and the team progress within the algorithm of care. Helps team members respond to the victim's changing condition. Used closed loop communication. Closed loop communication is an important technique used to prevent misunderstanding and treatment errors. It consists of the sender giving the message, the receiver repeating it back, and the sender then confirming it was heard correctly. To practice closed loop communication, the team leader and team members should do the following. Team leader will call each team member by name and make eye contact when giving an instruction. Do not assign additional tasks until you are sure the team member understands the instruction. Team members will confirm that they understand each task the team leader assigns to them by verbally acknowledging the task and tell the team leader when they have finished a task. Give clear messages to help prevent misunderstanding and keep everyone focused. All team members should use clear, concise language, speak loudly enough to be heard, speak in a tone that is both calm and confident, show mutual respect. All team members should display mutual respect and professional attitude regardless of each rescuer's skill level or training. Emotions can run high during a resuscitation attempt. It is especially important for the team leader to speak in a friendly, controlled voice and avoid shouting and aggression. Coaching and debriefing are important in every resuscitation attempt. During the event, the CPR coach will help improve performance of compression and ventilation by ongoing coaching. They also will work with the team leader to minimize pauses in the compressions during defibrillation and placement of an advanced airway. After the resuscitation event, debriefing is an opportunity for the team to discuss how the resuscitation went, identify why the team took certain decisions or actions, and discuss whether anything can be improved in the future events. Debriefing can occur immediately with the entire team or be scheduled at a later time with the team and others. It is an opportunity for education, quality improvement, and processing of emotions after participation in a stressful event. Debriefing has been shown to help individual team members perform better and aid in identifying the system's strengths and deficiencies. Implementing debriefing programs may improve patient survival after cardiac arrest. Review questions. After performing high quality CPR for 5 minutes, the team leader frequently interrupts chest compression to check for a pulse.
Which actions demonstrate constructive intervention? Suggest resuming chest compression without delay is the action which is constructive intervention. The team leader asks you to perform bag mask ventilation during a resuscitation attempt, but you have not perfected that skill. What would be an appropriate action to acknowledge your limitation? Tell the team leader you are not comfortable performing that task. What is the appropriate action to demonstrate closed loop communication when the team leader assigns you a task? You repeat back to the team leader the task assigned to you so that there is a closed loop communication. Pediatric BLS algorithm for healthcare providers, single rescuer. The pediatric BLS algorithm for healthcare providers outlines steps for a single rescuer of an unresponsive infant or child. Once you learn the skills presented, use the algorithm as a quick reference. The first rescuer who arrives at the side of an infant or child who may be in a cardiac arrest should follow these sequential steps on algorithm. Step 1, verify scene safety. Make sure the scene is safe for you and the victim. Step 2, check for responsiveness and get help. Tap the child's shoulder, shout, "Are you okay?" If the victim is not responsive, shout for help and activate the emergency response system via the mobile device if appropriate. Step 3, assess for breathing and a pulse. Check for a pulse to determine next actions. To minimize delay in starting CPR, you should assess breathing and pulse at the same time. This should take no more than 10 seconds. Step 3A and B, determine next actions based on whether breathing is normal and if a pulse is felt. If the victim is breathing normally and a pulse is felt, activate the emergency response system if not already done. Monitor the victim until emergency responders arrive. If the victim is not breathing normally but a pulse is felt, provide rescue breathing with one breath every 2 to 3 seconds or 20 to 30 breaths per minute. Assess the pulse rate for 10 seconds. Step 4, 4A and B. Is the heart rate less than 60 per minute with signs of poor perfusion? If yes, start CPR. If no, continue rescue breathing. Check for a pulse about every 2 minutes. If no pulse, start CPR. Steps 5 and 5A. Was the sudden collapse witnessed? If the collapse was witnessed, activate the emergency response system if not already done and get the AED. If the collapse was not witnessed, start CPR with cycles of 30 compressions and 2 breaths. Use an AED as soon as it is available. Step 7. After about 2 minutes, if you are still alone, activate the emergency response system and get an AED if not already done. Use the AED as soon as it is available. Follow the AED prompts or directions to check the rhythm. If the AED detects a shockable rhythm, give one shock. Resume CPR immediately until prompted by the AED to allow a rhythm check about every 2 minutes. Continue CPR and using the AED until advanced life support providers take over or the victim begins to breathe, move, or otherwise react. If the AED detects a non-shockable rhythm, resume high quality CPR until prompted by the AED to allow a rhythm check about every 2 minutes. Continue CPR and using the AED until advanced life support providers take over or the victim begins to breathe, move, or otherwise react. High quality CPR skills in infants and children. Mastering all the skills in this section will prepare you to provide high quality CPR to an unresponsive infant or child. Assess for breathing and a pulse. Checking the infant or child for normal breathing and a pulse will help you determine the next appropriate actions. You should assess breathing and pulse at the same time. Take no more than 10 seconds to check both so that you can start CPR quickly if necessary. Breathing. To check for breathing, scan the victim's chest for rise and fall for no more than 10 seconds. If victim is breathing, monitor the victim until additional help arrives. If the victim is not breathing or is only gasping, the victim has respiratory arrest, or if no detectable pulse, cardiac arrest. Gasping is not normal breathing and is a sign of cardiac arrest. Pulse. Infants. To perform a pulse check in an infant, feel for a brachial pulse. Here is how to check for the brachial artery pulse. You will place 2 or 3 fingers on the inside of the upper arm midway between the infant's elbow and shoulder and press your fingers down and attempt to feel the pulse for at least 5 but not more than 10 seconds. For a child to perform a pulse check in a child, feel for a carotid or femoral pulse. Check the carotid pulse for a child by using the same technique as for an adult. Here is how to check the femoral artery pulse. Place 2 or 3 fingers in the inner thigh midway between the hip bone and the pubic bone and just below the crease where the leg meets the torso. Feel for a pulse for at least 5 but no more than 10 seconds. It can be difficult for BLS providers to determine the presence or absence of a pulse in any victim, particularly in an infant or child. If you do not definitely feel a pulse within 10 seconds, start high quality CPR beginning with the chest compression. Signs of poor perfusion. Perfusion is the flow of oxygenated blood from heart through arteries to the body's tissues, and to identify signs of poor perfusion, assess following: temperature, cool extremities, altered mental status with continuous decline in consciousness or responsiveness, weak pulses, pale skin with mottling, patchy appearance of the skin, and later on cyanosis with blue lips or skin. Performing high quality chest compressions are the foundation of CPR. Perform compressions as described here to give an infant or child victim of cardiac arrest the best chance of survival. Compression to ventilation ratio for single rescuer is the same as in for adults, children, and infants, that is 30:2. However, when 2 rescuers are attempting to resuscitate an infant or child, they should use compression to ventilation ratio of 15:2. Compression rate is universal, 100 to 120 per minute. Compression depth for an infant is at least 1/3 of the anterior posterior diameter of infant's chest with approximation of 4 cm. For a child, compress at least 1/3 of AP diameter of the chest, 5 cm with each compression. Chest recoil during CPR. Chest recoil, that is re-expansion of chest, allows blood flow to flow into the heart. Incomplete chest recoil reduces the filling of the heart between compression and reduces the blood flow that chest compressions create. To help ensure complete recoil, avoid leaning on the chest between compressions. Chest compressions and chest recoil times should be about equal. Interruptions in chest compression. Minimize interruption in chest compression. Shorter duration of interruption in chest compression is associated with better outcomes. Chest compression technique for child, use 1 or 2 hands. For most children, compression technique is the same as for an adult with 2 hands, heel of one hand and the heel of the other hand on top of the first hand. For a small child, one-handed compressions may be adequate to achieve the desired compression depth. Whether you use one hand or both hands, compress at least 1/3 AP diameter of the chest, that is 5 cm with each compression. For infants, single rescuers can be either 2 fingers or 2 thumbs encircling hand technique. If multiple rescuers are present, the 2 thumb encircling hand technique is preferred. If you cannot compress the necessary depth on an infant with your fingers, you can use the heel of one hand. These techniques are described below. Infant 2 fingers technique. These steps are followed to give chest compression to infant by using 2 fingers with placing the infant on a firm flat surface. You place 2 fingers in center of infant's chest just below nipple line on the lower half of the breastbone.
or sternum. Do not press the tip of the breastbone. Give compressions at 100 to 120 per minute, at least one third of the AP diameter, about 4 centimeter in an infant. At the end of each compression, make sure you allow chest recoil, that is re-expansion, and do not lean on the chest of infant. Chest compression and chest recoil times should be about equal. Minimize interruptions in compression. If you go for breaths, you should reduce the interruption to less than 10 seconds. After every 30 compressions, open airway with head tilt, chin lift, and give 2 breaths each over 1 second. Chest should rise with each breath after about 5 cycles or 2 minutes of CPR. If you are alone and no one has activated the emergency response system, leave the infant or carry the infant with you and activate emergency response system and get the AED. Continue compression and breaths at a ratio of 30 to compressions to 2 breaths. Use the AED as soon as it is available. Continue until advanced life support providers take over or the infants begin to breathe, move, or otherwise react. Infant two thumb encircling hand technique is the preferred technique when two rescuers provide CPR to infant, but it can be used by the one rescuer as well. Two thumb encircling hand technique produces better blood supply to the heart muscle of an infant, helps ensure consistent depth and force of chest compression in an infant, and may generate higher blood pressures. Follow these steps to give chest compression to infant by using the two thumb encircling hand technique with placing the infant on a firm flat surface, placing both thumbs side by side in the center of the infant chest on the lower half of the breastbone. Your thumbs may overlap on very small infants. With the fingers of both hands, encircle the infant's chest and support the infant's back. With your hands encircling the chest, use both thumbs to depress the breastbone at a rate of 100 to 120 per minute, one third of the AP diameter of infant chest, approximately 4 centimeter. After each compression, release all pressure on the breastbone and allow the chest to recoil completely. After every 15 compressions, pause briefly for the second rescuer to open the airway with a head tilt, chin lift, and give 2 breaths each over 1 second. The chest should rise with each breath. Minimize interruptions in compression, for example, to give breaths to less than 10 seconds. Continue compressions and breaths at a ratio of 15 compressions to 2 breaths for 2 rescuers. The rescuers providing chest compression should switch roles with another provider every 2 minutes to avoid fatigue so that chest compression remain effective. Continue CPR until the AED arrives. Advanced life support providers take over and the infant begins to breathe, move, or otherwise respond. An additional alternative for compressions on an infant or child is to use the heel of one hand. This technique may be useful for larger infants or if the rescuer has difficulty compressing to the appropriate depth with their fingers and thumb. Critical concepts: compression depth in infants and children versus adults and adolescents. Infants, at least one third the AP diameter of the chest or approximately 4 centimeter. Children, at least one third the AP diameter of the chest or approximately 5 centimeter. Adults and adolescents, at least 5 centimeter. Give breaths. Breaths are important for infants and children in cardiac arrest. When cardiac arrest occurs suddenly, the blood's oxygen content is typically adequate to meet the body's oxygen demand for the first few minutes after the arrest. Thus, for witness sudden cardiac arrest, chest compressions alone can be effective way of distributing oxygen to the heart and brain. However, cardiac arrest in infants and children may not be sudden and it is often caused by respiratory complications. Infants and children who develop cardiac arrest often have respiratory failure or shock that reduces the oxygen content in the blood even before cardiac arrest occurs. As a result, for most infants and children in cardiac arrest, giving chest compressions alone does not deliver oxygenated blood to the heart and brain. as effectively as giving both compression and breath. Thus, it is vitally important that infants and children receive both compressions and breaths during high quality CPR. Opening the airway. For rescue breaths to be effective, the airway must be opened. Two methods for opening the airway are the head tilt chin lift and jaw thrust maneuver. As with the adults, if you suspect neck injury, use jaw thrust. If the jaw thrust does not open the airway, use the head tilt chin lift maneuver. Critical concepts in the infant CPR is that keep infant's head in neutral position. If you tilt, extend an infant's head beyond the neutral sniffing position, the infant's airway may become blocked. Maximize an open airway by positioning the infant with neck in a neutral position so that the external ear canal is level with the top of the infant's shoulder. Ventilation with a barrier device like a pocket mask or face shield or a bag mask device for delivering breath to an infant or child. When providing such breathing or ventilation to infant or child, do following. Select a bag and mask of appropriate size. The mask must cover the victim's mouth and nose completely without covering the eyes or extending below the bottom edge of the chin. Perform a head tilt chin lift to open the victim's airway. Press the mask to the face as you lift the jaw, making a seal between the child's face and the mask. Connect to supplemental oxygen when available. Pediatric BLS algorithm is for a multi-rescuer use in this setting. The first rescuer who arrives at the side of an unresponsive infant or child should quickly perform the first two steps on the algorithm. As more rescuers arrive, they assign roles and responsibilities. As a multi-rescuer team following the algorithm sequential steps, when more rescuers are available for a resuscitation attempt, they can perform some tasks at the same time. Verify scene safety and step 1, make sure that the scene is safe. Step 2 is check for responsiveness and get help. Tape the child's shoulder, shout, "Are you okay?" If the victim is not responsive, shout for help and activate the emergency response via mobile device if appropriate. The first rescuer remains with the victim while the second activates the emergency response and retrieves AED and emergency equipment. Step 3 is assessment of breathing and pulse and check for a pulse to determine next actions and to minimize delay in start of CPR. The breathing and pulse is checked at the same time and should not take more than 10 seconds. Step 3 and B determine next actions based on whether breathing is normal and if a pulse is felt. If the victim is breathing normally and pulse is felt, activate the emergency response. Monitor the victim until emergency responders arrive. If the victim is not breathing normally but as a pulse is felt, provide rescue breathing in one breath every 2 to 3 seconds or 20 to 30 breaths per minute. Assess the pulse rate for 10 seconds. For step 4, 4A and B, is the heart rate less than 60 per minute, less than 6 beats in 10 seconds with signs of poor perfusion? If yes, so then start CPR. If no, continue rescue breathing. Check for a pulse every 2 minutes. If no pulse, start CPR. In step 5, the first rescuer starts cycles of CPR with 30 compressions and 2 breaths. When second rescuer returns, continue cycles of CPR with 15 compressions and 2 breaths. Use the AED as soon as it is available. Follow the EED directions to check the rhythm in step 6. In step 7, if the AED detects a shockable rhythm, give one shock. Resume CPR until prompted by AED to allow rhythm check about every 2 minutes. Continue CPR and using the AED until advanced life support providers take over or the victim begins to breathe, move, or otherwise react. If the AED detects non-shockable rhythm in step 8, resume high quality CPR until prompted by AED to allow a rhythm check about every 2 minutes. Continue CPR and using the AED until advanced providers take over or the victim begins to breathe, move, or otherwise react. Review question: what is the correct compression to ventilation? Ratio for a single rescuer of a 3-year-old child: 30 compressions to 2 breaths. What is the correct compression to ventilation ratio for a 7-year-old child when 2 or more rescuers are present? 15 compressions to 2 breaths. For what age victim is the two-thumb encircling hand technique recommended? An infant younger than 1 year. What is the correct chest compression depth for a child? At least 1/3 of the depth of the chest, or approximately 5 cm, is the correct chest compression depth for a child. What is the correct chest compression depth for an infant? At least 1/3 of the depth of the chest, or approximately 4 cm. Rescuers may use an AED when attempting to resuscitate infants and children younger than 8 years of age. Most AED models are designed for both pediatric and adult resuscitation attempts. These AEDs deliver a reduced shock dose when pediatric pads are used. One common way to reduce a shock dose is by attaching a pediatric dose attenuator to AED. A pediatric dose attenuator reduces the shock dose an AED delivers. This attenuator uses child pads. An attenuator reduces the shock dose by about 2/3. Typically, an attenuator delivers the reduced shock via child pads. A pediatric dose attenuator frequently comes pre-connected to the pediatric pads. Choosing and placing the AED pads. Use the child pads if available for infants and for children younger than 8 years. If child pads are not available, use adult pads. Make sure the pads do not touch each other or overlap. Adult pads deliver a higher shock dose, but a higher shock dose is better than no shock. For pad placement, follow the AED manufacturer's instructions and the illustrations on the AED pads. Some AEDs require placing child pads in a front-back anterior-posterior AP position, while others require right-left, that is anterolateral placement. For infants, AP pad placement is common. AED used for victims 8 years of age and older. Use the AED as soon as it is available. Use adult pads. Do not use child pads. That is likely to result in a shock dose too low. Place the pads as illustrated on the pads. Place the pads directly on the skin of 8 years or older victims. Do not allow the pads to touch or overlap, and do not place on or over clothing. AED used for victims younger than 8 years. Use AED as soon as available. Use child pads if available. If you do not have child pads, you may use adult pads. Place the pads so that they do not touch each other. If the AED has a key or switch that will deliver a child shock dose, turn the key or switch. Place the pads as illustrated on the pads. Place the pads directly on the skin and do not place on or over clothing. AED used for infants. For infants, a manual defibrillator is preferred to an AED. A manual defibrillator has more capabilities than AED and can provide the lower energy doses that infants often need. This course does not cover how to use a manual defibrillator, a skill that will require advanced training. When a manual defibrillator is not available, an AED equipped with a pediatric dose attenuator is the preferred alternative. If neither is available, you may use an AED without a pediatric dose attenuator. Critical concepts in using adult pads or adult shock dose is better than no defibrillation for an infant or child.
AED pads. If you are using an AED for an infant or for a child younger than 8 years and AED does not have child pads, you may use adult pads. To ensure that the adult pads do not touch each other or overlap, you may need to place them anterior and posterior. Shock dose. If the AED you are using cannot deliver a pediatric dose, use the adult dose. Review questions. What should you do when using an AED on an infant or child younger than 8 years of age? Use adult AED pads if the AED does not have child pads. If a manual defibrillator is not available for an infant victim, which action should you take? Use an AED equipped with a pediatric dose attenuator. What is important to remember about AED placement on infants? You may need to place one pad on the chest and one on the back according to the diagrams given on the pads. As a BLS provider, you may be called on to help provide CPR in situations that require alternate ventilation techniques. If you are assisted advanced life support providers, you will need to know modifications to compressions and breaths once an advanced airway is placed. If a victim is unresponsive and not breathing but has a pulse, you will need to know how to perform rescue breathing. If a bag mask device is not available, you may need to give mouth to mouth or mouth to nose breaths. CPR and breaths with advanced airway. This section explains the modification to compressions and breaths that rescuer must make when an advanced airway is in place. Advanced airways prevent airway obstruction and can provide a route for more effective oxygenation and ventilation. Examples of advanced airways are laryngeal mask airway, supraglottic airway device, and endotracheal tube. Table 2 summarizes the compression to ventilation ratio with and without an advanced airway for adults and children and infants. When there is no advanced airway in place, ventilation technique is mouth to mouth, big mask device or pocket mask. When there is advanced airway in place, laryngeal mask airway, supraglottic airway device, endotracheal tube. So no advanced airway in place, compression rate of 100 to 120 and 30:2, and compression to breaths in infant and children, compression rate of 100 to 120 per minute, 30 compressions to 2 breaths for 1 rescuer and 15 compressions to 2 breaths in 2 rescuers. However, when there is advanced airway in place, compression rate of 100 to 120 per minute, continuous compressions without pauses for breaths, ventilation adult 1 breath every 6 seconds and infants 1 breath every 2 to 3 seconds. Rescue breathing is giving breaths to an unresponsive victim who has a pulse but is not breathing. You may provide rescue breathing by using a barrier device, for example, a pocket mask or face shield or bag mask device. If emergency equipment is not available, you may provide breaths by using the mouth to mouth technique or the mouth to mouth and nose technique. How to provide rescue breaths for adults, infants, and children. For adults, give 1 breath every 6 seconds. Give each breath over 1 second. Each breath should result in visible chest rise. Check for a pulse every 2 minutes. For infants and children, give 1 breath every 2 to 3 seconds. Give each breath over 1 second. Each breath should result in visible chest rise. Check for a pulse about every 2 minutes. When to switch from only rescue breathing to CPR in an infant or a child. When you are providing rescue breathing only, start CPR, compressions and breaths if you see the following, that is signs of poor perfusion in an infant despite effective oxygenation and ventilation provided by rescue breathing. The infant's or child's heart rate is less than 60 per minute with signs of poor perfusion, when a pulse is no longer felt. Then you will provide rescue breathing and start CPR if you see the following, especially when the pulse is not felt. Critical concepts: respiratory arrests occurs when normal breathing stops, preventing essential oxygen supply. Carbon dioxide exchange: lack of oxygen to the brain eventually causes a person to become unresponsive. Rescuers can identify respiratory arrest if all of the following signs are present. That is, victim is unresponsive, not breathing or only gasping, and the victim still has a pulse. Respiratory arrest is an emergency. Without immediate treatment, there will be brain injury, cardiac arrest, and death. In certain situations, including opioid associated life threatening emergencies, respiratory arrest is potentially reversible if rescuers treat it early. BLS providers must be able to quickly identify respiratory arrest, activate emergency response system, and begin rescue breathing. Quick action can prevent development of cardiac arrest. Techniques for giving breath without a barrier device. Many cardiac arrests happen in settings where rescue equipment is not available. So the techniques for giving breath when you do not have a barrier device such as pocket mask or bag mask device are discussed. Mouth to mouth breathing for adults and children. Mouth to mouth breathing is quick effective technique to provide oxygen to unresponsive adult or child. Follow these steps for mouth to mouth breath to adults and children. Hold the victim's airway open with a head tilt, chin left. Pinch nose closed with your thumb and index finger using the hand on the forehead. Take a regular, not deep breath and seal your lips around the victim's mouth, creating an airtight seal. Deliver one breath over 1 second. Watch for the chest to rise as you give the breath. If the chest does not rise, repeat the head tilt, chin lift. Give a second breath. Blow for about 1 second. Watch for the chest to rise. If you are unable to ventilate the victim after 2 attempts, promptly return to chest compressions. The method of giving mouth to mouth breaths. Breathing technique for infants. Use one of the following techniques to give breaths in infants: mouth to mouth and nose, mouth to mouth. The preferred technique for infants is mouth to mouth and nose. However, if you cannot cover the infant's nose and mouth with your mouth, use the mouth to mouth technique instead. Mouth to mouth and nose technique. Maintain a head tilt, chin lift to keep the airway open. Place your mouth over the infant's mouth and nose and create airtight seal. Blow into the infant's nose and mouth, pausing to inhale between breaths, just enough to make the chest rise with each breath. If chest does not rise, repeat the head tilt, chin lift to reopen the airway, and then try again to give a breath that makes the chest rise. It may be necessary to move the infant's head through the range of positions to provide effective breath. When airway is open, give breaths that make the chest rise. Mouth to mouth and nose breaths for infant victim. Mouth to mouth technique. Maintain a head tilt, chin lift to keep the airway open. Pinch the victim's nose tightly with your thumb and forefinger. Make a mouth to mouth seal. Deliver each mouth to mouth breath, making sure the chest rises with each breath. If the chest does not rise, repeat the head tilt, chin lift to reopen the airway. It may be necessary to move the infant's head through a range of positions to provide effective breaths. When the airway is open, give breaths that make the chest rise. Caution: risk of gastric inflation. If you give breaths too quickly or with too much force, air is likely to enter the stomach rather than lungs. This can cause gastric inflation with filling of stomach with air. Gastric inflation frequently develops during mouth to mask or bag mask ventilation. It can result in serious complications. To reduce the risk of gastric inflation, avoid giving breaths too quickly, too forcefully, or too much volume. But even if you give breaths correctly during high quality CPR, gastric inflation may still develop. So, to reduce the risk of gastric inflation, Deliver each breath over 1 second. Deliver just enough air to make the victim's chest rise. Which, which victim would need only rescue breathing? No breathing and a pulse would need only rescue breathing. How often should rescue breaths be given in infants and children when a pulse is felt? One breath every 2 to 3 seconds if the pulse is felt in an infant or child. Which action can rescuers perform to potentially reduce the risk of gastric inflation? Delivering each breath over 1 second reduces the risk of gastric inflation. Which is the preferred technique for giving rescue breaths to an infant? Mouth to mouth and nose is the preferred technique for giving rescue breaths to an infant. Deaths related to opioid use are increasing. The World Health Organization estimates that 27 million people suffer from opioid use disorders. Most use illicit drugs, but an increasing number are using prescribed opioids. Around the world, drug overdose involving opioids is the leading cause of injury related death. Opioid overdose does not just occur in addicts, it can occur in anyone who takes opioids or has access to opioids. Unintended overdose can happen at any time to any person of any age and in any place. Given this ongoing crisis, it is important to know what to do if you suspect opioid associated life threatening emergency in an unresponsive adult victim. So, first of all, what are opioids? Opioids are medications used primarily for pain relief. Common examples are hydrocodone, morphine, and fentanyl. Heroin is an example of an opioid. Problematic opioid use. Many people think that problematic opioid use happens only when someone takes an illegally produced or obtained opioid. Yet problems can occur when someone takes more drug than is prescribed, either purposely or accidentally, takes an opioid that was prescribed for someone else, combines opioid with alcohol or certain other drugs such as tranquilizers or sleeping pills, has certain medical conditions such as reduced liver function or sleep apnea, is older than 65 years of age. Too much opioid in the body can overwhelm the brain and depress the natural drive to breathe. This respiratory depression can result in respiratory arrest and cardiac arrest. Identifying opioid emergency. Scene assessment is important tool for identifying whether opioids may be involved in a life-threatening emergency. To evaluate the scene for potential opioid overdose, use these strategies. Communicate with bystanders. Ask questions such as, does anyone have an information about what happened? Do you know if the victim took anything? Observe the victim for signs of injection on the skin, medication patch, or other signs of opioid use. Assess the surroundings. Look for medication bottles or other signs of opioid use. Signs of an opioid overdose. Look for the following signs of an opioid overdose: slow, shallow or no breathing, choking or gurgling sounds, drowsiness or loss of consciousness, small constricted pupils, blue skin, lips or nails. Do not delay life-saving actions. After confirming scene safety, rescuers can perform the assessment at the same time as the resuscitation attempt. Antidote to opioid overdose: naloxone can temporarily reverse the effect of respiratory depression that opioids can cause. If available, give naloxone quickly by one of the delivery routes, that is intramuscular, intranasal, or intravenous, given by advanced providers. Naloxone auto-injector. Naloxone handheld auto-injectors deliver a single dose via intramuscular injection. Intranasal naloxone, an easy-to-use atomizer device, delivers intranasal naloxone into the nose
There is no risk of needle stick injuries with this method. Body quickly absorbs intranasal naloxone because the nasal cavity has relatively large surface of mucous membrane rich in capillaries. Critical concepts. What to do for an opioid associated life threatening emergency? If you suspect an opioid associated life threatening emergency, do the following. If the victim has a definite pulse but is not breathing normally, provide rescue breaths and give naloxone according to the package directions and per local protocols. Monitor for response. If the victim is in cardiac arrest and you suspect an opioid overdose, start CPR. Consider giving naloxone per package directions and per local protocols. Note that for victims who are in cardiac arrest from opioid overdose, the effect of administering naloxone is not known. Opioid associated life threatening emergency response sequence. The first rescuer who arrives at the side of an unresponsive victim and suspects opioid use should quickly follow these steps. As with any life threatening emergency, do not delay life saving actions. In step 1, if you suspect opioid poisoning, check to see if the patient is responding. Shout for nearby help, activate emergency response system. If you are alone, get naloxone and an EED if available. If someone else is present, send that person to get them. In step 2, is the person breathing normally? If the person is breathing normally, proceed with step 3 and 4. And if the person is not breathing normally, go to step 5. In step 3, prevent deterioration. Tap and shout. Check for responsiveness by tapping the victim's shoulders. Shout, "Are you okay?" Open and reposition the airway if needed to maintain normal breathing. This may be necessary if the victim is unresponsive or is responsive but unable to maintain an open airway due to depressed level of consciousness. Consider administering naloxone if available. If you suspect an opioid overdose, it is reasonable to give naloxone according to package directions and per local protocols. Monitor for response. Transport to the hospital. If the victim is not already in a healthcare setting, they should be transported by emergency medical services to a hospital. Step 4, assess for responsiveness and breathing. Continue to assess responsiveness and breathing until the victim is transferred to advanced care. Victims with opioid associated emergencies may not be able to maintain an open airway or breathe normally. Even those who receive naloxone may develop respiratory problems that can lead to cardiac arrest. In step 5, does the person have a pulse? Assess for a pulse for no more than 10 seconds. If yes, pulse is felt, go to step 6. If no, a pulse is not felt, go to step 7. In step 6, support ventilation. Open and reposition the airway before giving rescue breaths. Provide rescue breathing or bag mask ventilation. This can help prevent cardiac arrest. Continue until spontaneous normal breathing occurs. Reassess the victim's breathing and pulse every 2 minutes. If there is no pulse, provide CPR. Give naloxone according to package directions and local protocols. Start CPR. If the victim is not breathing and there is no pulse, provide high quality CPR including ventilation. Use the AED as soon as it is available. Consider naloxone. If naloxone is available and you suspect an opioid overdose, it is reasonable to give it according to package directions and per local protocol. High quality CPR should take priority over giving naloxone. Refer to the BLS protocol. Which of the following is not an opioid? Naloxone is not an opioid. Actually, naloxone is an opioid antagonist. Your roommate uses opioids. You find him unresponsive and no breathing, but he has a strong pulse. You suspect opioid overdose. A friend is phoning the local emergency and looking for naloxone auto injector. What action should you take? Provide rescue breathing, one breath every 6 seconds until the emergency responders arrive. You encounter unresponsive 56-year-old woman who has been taking hydrocodone for post-surgical pain. She is not breathing and has no pulse. You notice that her medication bottle is empty and suspect opioid-associated life-threatening emergency. A colleague activates emergency response system and is retrieving the AED and naloxone. What is the most appropriate action for you to take next? The next step for this 56-year-old woman is to begin CPR, starting with chest compressions.
Heart disease has been the leading cause of death in the US for both men and women for decades. Every 40 seconds, a person in US has a heart attack. A heart attack occurs when a blockage forms or there is a severe spasm in the blood vessel that restricts the flow of blood and oxygen to the heart muscle. During heart attack, the blood is not pumped by the heart, but the longer the victim with a heart attack goes without treatment to restore blood flow, the greater the possible damage to the heart muscle. Sometimes the damaged heart muscle triggers an abnormal rhythm that can lead to sudden cardiac arrest. Signs of heart attack may occur suddenly and be intense. Yet many heart attacks start slowly with mild pain or discomfort. Activate emergency response system if someone is having signs of heart attack. Chest discomfort. Most heart attacks involve discomfort in the center of the chest that lasts more than a few minutes and often does not resolve with rest. The discomfort may go away with the rest and then return. It can feel like uncomfortable pressure, squeezing, fullness, or pain. Discomfort in other areas of the upper body. Symptoms can include pain or discomfort in the left arm, commonly, but can occur in both arms, the upper back, neck, jaw, or stomach. Shortness of breath can occur with or without chest discomfort. Breaking out in a cold sweat, nausea, vomiting, or lightheadedness are other signs of heart attack. The typical signs of a heart attack are based on the experience of white middle-aged men. Women, the elderly, and people with diabetes are more likely to have less typical signs of heart attack, such as shortness of breath, weakness, unusual fatigue, cold sweat, and dizziness. Women who report chest discomfort may describe it as a pressure, aching, or tightness rather than as pain. Other less typical signs are heartburn or indigestion, an uncomfortable feeling in the back, jaw, neck, or shoulder, and nausea or vomiting. People who have trouble communicating may not be able to articulate signs of heart attack. People often use the terms heart attack and cardiac arrest to mean the same thing, but they are not the same thing. A heart attack is a blood flow problem. It occurs because a blockage or spasm in blood vessels severely restricts or cuts off the flow of the blood and oxygen to the heart muscle. Sudden cardiac arrest is usually a rhythm problem. It occurs when the heart develops an abnormal rhythm. This abnormal rhythm causes the heart to quiver or stop completely and no longer pumps blood to the brain, lungs, and other organs. Within seconds, the victim in cardiac arrest becomes unresponsive and is not breathing or is only gasping. Death occurs within minutes if the victim does not receive immediate life-saving treatment. Heart attack happens more frequently than cardiac arrest. Although most heart attacks do not lead to cardiac arrest, they are a common cause. Other conditions that change the heart rhythm may lead to cardiac arrest as well. Obstacles to life-saving treatment. Early recognition, early intervention, and early transport of someone with suspected heart attack is critical. Early access to emergency medical system is often delayed because both the victim and the bystander fail to recognize the signs of a heart attack. Life-saving treatment can be delivered by emergency medical providers on the way to the hospital, saving precious minutes and heart muscle. Many people won't admit that their discomfort may be caused by a heart attack. People often say the following: I am too healthy or I am too young. I don't want to bother the doctor. I don't want to frighten my spouse. I will feel silly. If it is not a heart attack, it's just indigestion. If you suspect someone is having a heart attack, act quickly and activate emergency response. Do not hesitate even if the victim doesn't want to admit discomfort. Actions to help a heart attack victim. Heart attack is a time critical emergency. Every minute counts. If you think someone is having a heart attack, do the following. Have the victim sit and remain calm. Activate emergency response or ask someone else to do so. Get the first aid kit and EED available. Encourage alert adults who are experiencing chest pain to chew and swallow aspirin unless they have a known aspirin allergy or have been told not to take aspirin by a healthcare provider. If the victim becomes unresponsive and is not breathing or is only gasping, start CPR. Effective treatment of heart attack requires well coordinated, timely system of care. Time is muscle, every minute counts. The longer a heart attack victim waits for a treatment, the more damage to the heart muscle. Timely interventions by healthcare providers in the hospital to run the blood coronary can determine the amount of damage to the heart muscle. One common intervention is non-surgical treatment, cardiac lab, administration of IV medications in ED is another intervention. Actions of healthcare providers during the first several hours of a heart attack determine how much the patient will benefit from treatment. The goal is to decrease time from symptom onset until the blockage is resolved. Here are the steps in out of the hospital system of care for heart attack. Early recognition and call for help. The more quickly first responders or family recognize warning signs of heart attack, the sooner treatment can begin. Emergency response system should be activated immediately for triage and transport. Family members should not drive the suspected heart attack victim to hospital. Victims should not drive themselves as well. Emergency responders can provide some interventions that at the scene or during transport, thus lessening the delay to the definitive treatment in the hospital. Early EMS evaluation and 12-lead ECG. The 12-lead ECG is the central component of triage of patients with chest discomfort. When EMS providers are able to perform a 12-lead ECG and transmit results to the receiving hospital, time to treatment is decreased. The ECG may be done at the scene or during transport. Early heart attack identification. Once providers confirm heart attack, they communicate with the advanced care providers and transport the patient to the most appropriate hospital. Early notification. EMS providers notify the receiving facility as soon as possible for an incoming heart attack patient. The cath lab team is activated before the patient's arrival. EMS activation of the cardiac cath lab speeds the time to diagnosis and intervention. Early intervention, the goal time from initial contact to treatment is less than 90 minutes. Early recognition, early EMS activation, early transport by EMS, and early intervention for someone with suspected heart attack is critical. Goal is 90 minutes from initial contact to treatment intervention. Learn to recognize the signs of a heart attack. Activate emergency response system without delay. Give aspirin if indicated. Be prepared to start CPR if the victims become unresponsive. Stroke. Every 40 seconds, someone in US has a stroke. More than 795,000 people have a stroke every year. Stroke is the leading cause of serious long-term disability and fifth leading cause of death. A stroke occurs when blood stops flowing into the brain. This can happen if an artery in the brain is blocked. Ischemic stroke or blood vessel burst. Hemorrhagic stroke. Brain cells begin to die when minutes without blood and oxygen. Treatment in the first hours after stroke can reduce damage to the brain and improve recovery. Use FAST method to recognize and remember the warning signs of stroke. FAST stands for face drooping, arm weakness, speech difficulty, and time to phone the local emergency number. If you see any of these signs, act fast. Face drooping. Does one side of the face droop or is it numb? Ask the person to smile. Arm weakness. Is one arm weak or numb? Ask the person to raise both arms. Does one arm drift downwards? Speech difficulty. Is speech slurred? If the victim is the victim unable to speak or hard to understand, ask the person to repeat a simple sentence like the sky is blue. Is the sentence repeated correctly? And T, time to phone the local emergency number. If the person shows any of these symptoms, even if symptoms go away, phone the local emergency number and get them to the hospital immediately. Other signs of stroke. Be alert for other common signs of stroke such as sudden dizziness, trouble walking, or loss of balance or coordination, sudden trouble seeing in one or both eyes, sudden severe headache with no known cause, sudden numbness of the face, arm, or leg, sudden weakness in the part of the body, sudden confusion or trouble understanding others. Actions to help a stroke victim. Stroke is a time critical emergency. Every minute counts. If you think someone has had a stroke, do the following. Quickly evaluate the victim for signs of stroke. Activate emergency response system or have someone else to do it. Find out what time the signs of stroke first appeared. Remain with the victim until someone with more advanced training arrives and takes over. If the victim becomes unresponsive and is not breathing normally or is only gasping, give CPR. System of care. Effective stroke treatment requires a well coordinated, timely system of care. Delay at any step limits treatment options. The longer stroke patient waits for treatment, the more brain tissue dies. Drugs that break up a clot must be given within about 3 hours after the onset of signs. Providers must know the last known well time. This is the point at which the patient was last known to be well without signs of stroke. Here are the steps in out of the hospital system care for stroke: recognition, EMS dispatch, EMS identification, management and transport, triage, evaluation and management, treatment decision and therapy. System of care. Effective stroke treatment requires well coordinated, timely system of care. Delay at any step limits treatment options. The longer the stroke patient waits for treatment, the more brain tissue dies. Drugs that break up a clot must be given within about 3 hours after the time the signs first started. Providers must know the last known well time. This is the point at which patient was last known to be well without signs of stroke. Here are the steps in out of hospital system of care for stroke recognition. The more quick first responders or family recognize the warning signs of stroke, the sooner treatment can begin. Patients who do not get to the emergency department within a 3-hour window from the onset of symptoms may not be eligible for certain types of therapy. EMS dispatch. Someone should phone the local emergency number and get EMS on the way as quickly as possible. Family members should not transport the stroke victim to the hospital themselves. EMS identification, management and transport. EMS will determine if the patient is showing signs of stroke and obtain important medical history. They will begin management and transport to the next level of care. EMS will call ahead to the receiving hospital to alert providers that a potential stroke patient will soon be arriving. Triage. The patient should be triaged to the closest available stroke center or a hospital that provides emergency stroke care. Evaluation and management. Once the patient arrives at the emergency department, evaluation and management should proceed immediately. Treatment decisions. Providers with stroke expertise will determine appropriate therapy. The gold standard for ischemic stroke is an IV administration of alteplase. To be effective, alteplase must be given within about 3 hours after the time of signs starting. Another option is thrombectomy, an invasive procedure that removes the clot from inside the blood vessel or artery. Critical concepts is time is brain. Stroke is a time critical emergency. Every minute treatment is delayed, more brain tissue dies. Priorities are early recognition, limited scene time, and transport to the appropriate facility. Drowning. Drowning is the third leading cause of injury and death worldwide. The United States In the United States, drowning is second leading cause of injury, death for children aged 1 to 14. Non-fatal drowning injuries can cause severe brain damage resulting in disabilities and permanent loss of basic functioning. Rescue actions based on cause of cardiac arrest. BLS providers may need to tailor rescue actions to the most likely cause of arrest. For example, if you are alone and see someone suddenly collapse, then it is reasonable to assume that the victim has had a sudden cardiac arrest. The steps for a sudden cardiac arrest are to activate the emergency response system, get an AED, and then return to the victim to provide CPR. CPR for a victim of sudden cardiac arrest begins with chest compression. The sequence for a victim of drowning is different. Cardiac arrest in a drowning victim is caused by severe lack of oxygen in the body, that is, asphyxial arrest. The priority is to get oxygen to the brain, heart, and other tissues. Actions to help a victim of cardiac arrest due to drowning. Follow these steps along with adult BLS algorithm to help a victim of cardiac arrest due to drowning. Call for help, ask someone to activate emergency response system, get to the victim as quickly as possible, move the victim to shallow water or out of the water. Pay attention to your own personal safety during the rescue process. Check for breathing. If there is no breathing, open the airway. Give 2 rescue breaths that make the chest rise. Avoid delays in beginning CPR. Use mouth to nose ventilation as an alternative to mouth ventilation if needed. Sometimes it is difficult for the rescuer to pinch the victim's nose. Support the head and open the airway if the victim is still in the water. You do not need to perform routine spinal stabilization unless there are signs that the victim may have had head or neck injury. Do not try to clear the airway of aspirated water. Most drowning victims only aspirate a modest amount of water and it is absorbed rapidly. Do not use abdominal thrusts to remove water from the breathing passages. These actions are not recommended and can be dangerous. Check for a pulse after giving 2 effective breaths. If the victim is not breathing normally but has a pulse, provide rescue breathing only. Recheck for a pulse every 2 minutes. If you do not feel a pulse, start CPR. Start CPR with cycles of 30 compressions and 2 breaths. Give 5 cycles about 2 minutes and then activate the emergency response system if not already done. Use the AED as soon as it is available. Attach the AED once the victim is out of the water. You only need to dry the chest area quickly before applying the AED pads. Follow the AED prompts. If no shock is needed and after any shock delivery, immediately resume CPR starting with chest compression. Vomiting during resuscitation. The victim may vomit during rescue breaths or chest compression. If this happens, turn the victim to the side. If you suspect a spinal cord injury, roll the victim so that head, neck, and torso are turned as a unit. This will help protect the cervical spine. Remove the vomit using your finger or a cloth. You may use suction if within your scope of practice. Transport. All victims of drowning should be transported by emergency medical services to the emergency department for evaluation and monitoring. This includes victims who needed only rescue breaths or those who are alert and seem to have recovered. Although survival is uncommon in victims who have been underwater for a long time, there have been cases of successful recovery, especially when in cold water. For this reason, rescuers should provide CPR at the scene and the victim should be transported in accordance with local protocols. Critical concepts. Rescue breathes first. The first and most important action for a drowning victim is to give rescue breaths as soon as possible. This action increases the victim's chance of survival. Anaphylaxis. Most allergic reactions are mild. Some, however, worsen to a state of anaphylaxis. Anaphylaxis is a severe allergic reaction that requires urgent treatment. Treatment may include an epinephrine injection. Prompt recognition is critical. You must be able to identify if an allergic reaction is mild or severe. Anaphylaxis. Mild allergic reaction. Signs of a mild allergic reaction are stuffy nose, sneezing and itching around the eyes, itching of the skin or mucous membrane, a raised red rash on the skin or hives. Action for mild allergic reaction is to get help, remove the victim from allergen if known, move out of the environment, wash the affected area of skin, ask about any history of allergy or anaphylaxis, look for a medical alert bracelet or necklace, consider an oral dose of antihistamine. Severe allergic reaction anaphylaxis can be life threatening if not recognized and treated immediately. Anaphylaxis occurs suddenly after contact with an allergen. Some common allergens associated with anaphylaxis are medicines, latex, food, and stinging insects. In anaphylaxis, two or more body systems are involved. Signs of a severe allergic reaction include breathing problems like swelling of the airway with trouble breathing and abnormal breathing sounds such as wheezing. In the skin, hives, itching, flushing, and swelling of lips, tongue, and face. In circulation, signs of poor perfusion or shock, which may include very fast heart rate, changes in skin color, cool skin, not alert, low blood pressure, and in gastrointestinal system, stomach cramping, and diarrhea. Criteria for anaphylaxis. Many providers have trouble recognizing anaphylaxis. Look for following four criteria. Signs that come on quickly and rapidly get worse. Skin changes such as flushing, itching, and swelling of lips, tongue, and face. Life threatening airway, breathing, and circulation problems. Involvement of two or more body systems. Remember that skin changes alone are not a sign of anaphylactic reaction. Epinephrine auto-injector for a severe allergic reaction. Epinephrine can temporarily relieve the life-threatening problem caused by severe allergic reaction. Epinephrine is available by prescription in self-injectable device called epinephrine auto-injector. People who are known to have severe allergic reactions are encouraged to carry the epinephrine auto-injectors with them all the time. There are two types of epinephrine auto-injectors, spring-activated and electronic. The doses are different for children and adults. The epinephrine injection is given in the side of the thigh, about halfway between the hip and the knee. This is the safest location for administration. Epinephrine can be given on bare skin or through clothing. Someone who has an epinephrine auto-injector will generally know how and when to use it. If the person is unable, you may help give the injection if the medication has been prescribed by a physician and the state law permits it. Actions to help someone with a severe allergic reaction. A severe allergic reaction can be life threatening. Follow these steps to help someone with suspected anaphylaxis. Activate emergency response system or ask someone else to do so. Send someone to get the person epinephrine auto injector. Give or help the patient inject epinephrine with an epinephrine auto-injector as soon as possible. Send someone to get the AED. Give a second dose of epinephrine if the person has continued symptoms and advanced care will not arrive in 5 to 10 minutes. If the person becomes unresponsive and is not breathing or is only gasping, start CPR. You may give epinephrine by epinephrine auto-injector during cardiac arrest. If possible, save a sample of what caused the reaction, give it to the advanced responders. Critical concepts with life-saving actions for anaphylaxis, and the first and foremost important action for someone with suspected anaphylaxis to give an immediate injection of epinephrine using their epinephrine auto-injector. How to use auto-injector? You should know the correct technique for using auto-injector. Some devices give voice prompts to guide user through the administration of epinephrine dose. Device safety. Before using epinephrine auto-injector, quickly examine it to make sure it is safe to use. Do not use it if the solution is discolored when it is possible to see the medicine. Clear window on the auto-injector is red, then don't use. Steps for using epinephrine auto-injector. Follow these steps to correctly use the epinephrine auto-injector. Follow the instructions on device. Make sure you are holding the device in your face without touching either end, because the needle comes out of one end. You may give the injection through clothes or on bare skin. Take off the safety cap. Hold the leg firmly in place just before and during the injection. Press the tip of injector hard against the side of the patient thigh, about halfway between hip and knee. For epinephrine auto injectors, hold the injector in place for 3 seconds. Some other injectors may be held in place for up to 10 seconds. Be familiar with the manufacturer's instructions for the type of injector you are using. Pull the injector straight out. Make sure you do not put your fingers over the end that has been pressed against the person's thigh. Either the person getting the injection or the one giving the injection should rub the injection spot for about 10 seconds. Note the time of injection. Properly dispose of the injector. Ensure that EMS is on the way. If there is a delay of greater than 5 to 10 minutes for advance help to arrive, consider giving a second dose if available. Take off the safety cap and press the tip of the injector hard against the side of the thigh about halfway between the hip and the knee as shown in the diagrams. Safe disposal. It is important to dispose of used needles correctly so that no one gets stuck. Follow the shop's disposal policy at your workplace. If you don't know what to do with the used injector, give it to someone with more advanced training. Which of the following population is most likely to show atypical signs of heart attack like shortness of breath and dizziness? Individuals with diabetes. What does the stroke acronym FAST stand for? Face drooping, arm weakness, speech difficulty, time to phone the local emergency number. If you think someone might be having a stroke, what should you do first? Quickly check for signs of stroke. How are rescue actions for cardiac arrest due to drowning different from the rescue actions for sudden cardiac arrest? Unlike sudden cardiac arrest, the priority in drowning is to give the person oxygen. You are attempting to rescue a person who has experienced drowning. What do you do if there are no signs of breathing? Open the airway and administer rescue breaths. Which of the following is a sign that someone is experiencing anaphylaxis? Life-threatening breathing or circulation problems indicate that the person is experiencing anaphylaxis. You notice someone showing all signs of a severe allergic reaction. What is the first and most important action you should take? The first and foremost important action is to use the epinephrine device in case the patient is showing signs of severe allergic reaction. Another topic of BLS is choking relief for adults. So, what are the signs of choking? Early recognition of foreign body airway obstruction is the key to successful outcome in such situations. It is important to distinguish this emergency from fainting, stroke, heart attack, seizure, drug overdose, or other conditions that may cause sudden respiratory distress but require different treatment. Foreign bodies may cause a range of signs from mild to severe airway obstruction. So, mild airway obstruction will have good air exchange. Patient can cough forcefully, maybe between coughs. Severe obstruction will have clutching the throat with the thumb and fingers, making the universal choking sign, unable to speak or cry, poor or no air exchange, weak ineffective cough or no cough at all, high pitched noise while inhaling or no noise at all, increased respiratory difficulty, possible cyanosis, blue lips or skin. The universal choking sign indicates the need for help when a victim is choking. So, when there is mild airway obstruction, the rescuer actions include, as long as good air exchange continues, encourage the victim to continue coughing. Do not interfere with the victim's own attempts to relieve the obstruction. Stay with the victim and monitor the condition. If mild airway obstruction continues or progress to signs of severe airway obstruction, activate the emergency response system. In case of severe airway obstruction, if the victim is an adult or child, ask
Are you choking? If the victim nods yes and cannot talk, severe airway obstruction is present. Take steps immediately to relieve the obstruction. If severe airway obstruction continues and the victim becomes unresponsive, start CPR. If you are not alone, send someone to activate the emergency response system. If you are alone and must leave to activate emergency response system, provide about 2 minutes of CPR before leaving. Choking relief in a responsive adult or child. Abdominal thrusts. Use abdominal thrusts to relieve choking in a responsive adult or child. Do not use abdominal thrusts to relieve choking in an infant. Give each individual thrust with intention of relieving the obstruction. It may be necessary to repeat the thrust several times to clear the airway. Abdominal thrust with the victim standing or sitting. Follows these steps to perform abdominal thrusts on a responsive adult or child who is standing or sitting. Stand or kneel behind the victim and wrap your arms around the victim's waist. Make a fist with one hand. Place the thumb side of your fist against the victim's abdomen in the midline, slightly above the navel and well above the breastbone. Grasp your fist with your other hand and press your fist into victim's abdomen with a quick, forceful upward thrust. Repeat thrusts until the object is expelled from the airway or the victim becomes unresponsive. Give each new thrust with a separate, distinct movement to relieve the obstruction. Here is the method of abdominal thrusts with the victim standing. Choking relief in pregnant and obese victim. If the victim is pregnant or obese, perform chest thrusts instead of abdominal thrusts. Chest thrusts used in the obese or pregnant patients. Choking relief in an unresponsive adult or child. A choking victim's condition may worsen and the victim may become unresponsive. If you are aware that a foreign body airway obstruction is causing the victim condition, you will know to look for a foreign body in the throat. To relieve choking in an unresponsive adult or child, follow these steps. First, shout for help. If someone else is available, send that person to activate the emergency response system. Gently lower the victim to the ground if you see that they are becoming unresponsive. Begin CPR starting with chest compression. Do not check for a pulse. Each time you open the airway to give breath, open the victim's mouth wide. Look for the object. If you see an object that looks easy to remove it with your fingers. If you do not see an object, continue CPR. After about 5 cycles or 2 minutes of CPR, activate the emergency response system if someone has not already done so. If a choking victim is already unresponsive when you arrive, you probably will not know if a foreign body airway obstruction exists. In this situation, you should activate the emergency response system and start high quality CPR, giving effective breaths when there is an airway obstruction. When a choking victim loses consciousness, the muscles in the throat may relax. This could convert a complex or severe airway obstruction to a partial obstruction. In addition, chest compressions may create at least as much force as abdominal thrusts, so they may help expel the object. Giving 30 compressions and then removing any object that is visible in the mouth may allow you to eventually give more effective breaths. Actions after choking relief. You will know you successfully removed an airway obstruction in an unresponsive victim if you saw and removed a foreign body from the victim's mouth and the victim started to breathe. However, you do not always have to remove the foreign body to successfully relieve the obstruction. If you can feel air movement and see the chest rise when you give breaths, the airway is no longer obstructed. After you relieve choking in an unresponsive victim, proceed as you would with any unresponsive victim. Check again for responsiveness, check for breathing and a pulse. Confirm that someone has activated the emergency response system and provide high quality CPR or rescue breathing as needed. Encourage a responsive victim to seek immediate medical attention. A healthcare professional should evaluate the victim for potential complications from abdominal thrusts. Choking relief in infants. Responsive infant use back slaps and chest thrusts for choking relief in an infant. Do not use abdominal thrusts. To relieve choking in a responsive infant, follows these steps. Kneel or sit with the infant in your lap. Hold the infant face down with head slightly lower than the chest, resting on your forearm. Support the infant's head and jaw with your hand. Take care to avoid compressing the soft tissue of the infant's throat. Rest your forearm on your lap or thigh to support the infant. With the heel of your hand, deliver up to 5 forceful back slaps between the infant's shoulder blades. Deliver each slap with enough force to attempt to dislodge the foreign body. After delivering up to 5 back slaps, place your free hand on the infant's back. So, after delivering up to 5 back slaps, place your free hand on the infant's back, supporting the back of the infant head with the palm of your hand. The infant will be adequately cradled between your two forearms with the palm of one hand supporting the face and jaw, while the palm of the other hand supports the back of the infant's head. Turn the infant over while carefully supporting the head and neck. Hold the infant face up with your forearm resting on your thigh. Keep the infant's head lower than the trunk. Provide up to 5 quick downward chest thrusts in the middle of the chest over the lower half of the breastbone, the same location as for chest compression during CPR. Deliver chest thrusts at a rate of about 1 per second each with the intention of creating enough force to dislodge the foreign body. Repeat the sequence of up to 5 back slaps and up to 5 chest thrusts until your actions have removed the object or the infant becomes unresponsive. This is the method to give back slaps. Chest thrusts given in an infant with airway obstruction. If the infant victim become unresponsive, stop giving back slaps and start CPR starting with chest compressions. To relieve choking in an unresponsive infant, follow these steps. First, shout for help. If someone responds, send that person to activate the emergency response system. Place the infant on a firm, flat surface. Begin CPR starting with compression with one extra step. Each time you open the airway, look for the object in the back of the throat. If you have an object can be easily remove it. Note that you do not check for a pulse before beginning CPR. After about 2 minutes of CPR, activate emergency response system if no one has done so. Critical concepts: no blind finger sweeps. Do not perform a blind finger sweep because it may push the foreign body back into the airway, causing further obstruction or injury, which is an example of a mild foreign body airway obstruction. Wheezing between cough is an example of a mild foreign body airway obstruction. Which victim of a severe airway obstruction should receive abdominal thrusts? Here, an average size 27-year-old man should receive abdominal thrust if he has severe airway obstruction. You are performing abdominal thrusts on a 9-year-old child when she suddenly becomes unresponsive. After you shout for nearby help, what is the most appropriate action to take next? Begin high quality CPR starting with chest compression after you shout for nearby help.